pandemic has led to an unprecedented chapter in the history of Foxy, in the history of our nation, and all of us as practitioner. As you all know, the theme for the Foxy for this year's activity is safety first for women of India and Foxians, and now it looks very pertinent for this year. Uh, Fortunately, compared to other countries, India is doing well. And just yesterday, during the press conference, Love Agrawal, Joint Secretary Health and Family Welfare, during the press conference just 24 hours back, he has informed uh, and presented some good data. 68,000 cases total identified in India, and out of this, 716 cases identified in 24 hours. Total test done in India is 1,60,000 till today. General population 0.3% positive, and SARI 1.8% positive. There is, as per the government, there is no community transmission at present. COVID-19 test done by 213 laboratories in India, out of which 66 are private laboratories, and many routine non-COVID-19 patients being managed by telemedicines now. All essential services as per the routine are going on, and as per ICMR, Mr. Pranav is with us. As per ICMR, the number would have been much higher if lockdown is not started. And as per the Oxford University also gives very high score to India for COVID-19 management, but always there is a scope for improvement for the safety. We at Foxy also trying to track each COVID-19 pregnant women. Till today, we are knowing 10 cases of pregnancy with confirmed COVID-19 infection out of these 6,800 cases. But there may be many more patients. We may not know them or they are not diagnosed. While the common advice is to stay home, we have to perform our duty. We have a duty to serve our patients even in these trying times. And it is said that nearly more than 75 or 80 healthcare workers, frontline healthcare workers, are infected, and a death of few doctors are also reported. The cause we are not knowing, maybe because of the infection or maybe because of some other cause. But looking to the ratio of pregnant women affected, 10 at present, plus we may not know many others, and looking to the number of healthcare provider infected, nearly 75 or 80, more than 80, this ratio of pregnant women and healthcare worker providers infected is probably maybe more higher than China, Germany, Singapore, South Korea, Hong Kong, and many other countries. So on one side, there is a good that we can control the spread of the pandemic and we can limit it to 6,800 cases. But at the same time, looking to the number of pregnant women infected and at the same time healthcare workers infected is not such a small figure. If it continues like this, we hope that we will not reach to a stage of China, but then the number in thousands of cases will also be increased like this. And that is why we are worrying for the safety of our pregnant women and healthcare workers. While conducting delivery or performing cesarean section or MTP, we may be in close contact of our patients who may be asymptomatic but may be carrier. Government of India is trying its best, but still personal protective equipments are not available in sufficient quantity, and quality of PPE is also one issue. There is a small survey conducted by me, and I have communicated with few head of the department of few medical colleges, and I came to know that PPE are not enough in quantity. and they are making their own innovative ways to protect themselves and postgraduate students. So we are also not promoting diagnostic tests like in some other countries. So looking to all these, on one side we can control the pandemic in up to 6,800. At the same time, certain things are there. So therefore the precaution safety measures recommendations are necessary to protect our pregnant women as well as healthcare workers. So looking to all these factors and its importance, today we have decided to discuss the topic of safety first during COVID-19 pandemic. And we also would like to discuss few real case scenarios, because we have some eminent faculties with us who are managing the patients with COVID-19 infections at present. So all three eminent gynecologists with us are managing COVID-19 pregnant women. At the same time, we have some policy makers who has some influence in making policy are also with us for discussion. I welcome Dr. Pranab from ICMR. I also welcome Dr. Ram from WHO. And let us start our discussion with, I think we'll start with Mr. Pranab, ICMR. Are you on, Mr. Pranab?
Yes, I'm on.
So there are many centers are now getting cases who do not have any history of travel or any contact of an infected person. So is this a sign of community spread or not, and why?
So the most important issue here is to consider what exactly is meant by community spread. At this
Yes.
point of time, what we are seeing is localized transmission, and even India is not classified to have what is traditionally understood by community transmission. So right now, given the way we have limited the spread of COVID-19 in the country, we are not in a state of community spread, but we have to prepare so that if and when it happens, we have to be able to mount a meaningful response to it.
So it's good we are in a preparation stage, and we hope that it will not reach to a community level. Uh, our worry is when we are having a patient with labor pain, it is not a, sometimes some conditions are that like a fever, we have to examine the patient for 2 or 5 minutes or 10 minutes, and then we are not in contact with the patient. But here when patient, a normal patient, asymptomatic patient comes to us for labor pain, we will be in contact with the patient throughout the day. It is not a, so we will be in prolonged contact, not only in contact, but in prolonged contact. At the same time, we have to examine the patient frequently for fetal heart sound and progress of the labor. So we are worrying that we are in contact for a prolonged time. At the same time, we are in frequent contact. And at the same time, when she delivers, a big team is required, which includes nurse, which includes neonatologists, anesthetists, a big team is there. So if by chance, if she is asymptomatic but carrier or suspecting, it can spread to so many patients. And more worry is after delivery, we are usually discharging our patient within 24 to 36 hours. And then we lost follow-up with the patient. And suppose by chance she turned to be positive at her home, and we are not knowing, and in the same labor room or in the same operation theater, then we are conducting delivery of other patients. So other normal patients can be infected because of this. So looking to all these things, can we do something special considering this category as something special, a pregnancy with labor pain? And can we include this condition for the rapid diagnostic test? First of all, is it available? When it will become available? What is the significance of this rapid diagnostic test? And if it is available and if it is affordable, can we include this rapid diagnostic test for a patient who are having labor pain or undergoing cesarean section, or to whom we have to perform MTP?
Okay, thank you, sir. This is a really good question. First thing is that whenever attending to a patient with a suggestive clinical picture, it would be prudent to maintain the universal precautions so that the infection is not spread. Secondly, it would, like you pointed out, a large number of healthcare providers are needed for um, for the management of the patient. So it would be prudent to limit the number of providers in contact with the patient. Hello, can you hear me?
Yes,
Am
yes,
I?
we can.
Yeah, okay. Thirdly, even if rapid tests are done, given the way the currently we are only considering antibody-based rapid tests. Given the way the antibody levels alter in the blood, it takes around 7 days for most of the tests to become positive. So even with the availability of rapid tests, it becomes important to not overuse or over-test with them. As far as symptomatic proportion is concerned, most people who have a symptom will have fever. It is one of the most common symptomatic presentations. So there is need to maintain certain precautions for febrile cases. And when the tests will be available, it is expected that the tests are going to be available in the next few days. There have been a lot of sort of arrangements to get the tests availed, and there has been a global short supply, not just here, but also globally. So getting through all of that, plus it has to be that the tests are reliable. Not every test has a very good sensitivity and specificity. So that you can give care to a patient appropriately, we have to make the tests which are more reliable available to all the healthcare providers.
So there are two things you have mentioned: standard precautions, universal precautions, but it does not involve everything which usually required to which routinely involved in PPE. And second thing you have mentioned regarding the fever. So do you want to suggest, if patient is having a fever, labor pain patient having fever, should we request advice for investigation, screening test, or does not require?
Okay. So the PPE is the full hazmat-like PPE that may not always be required. Um, Protection from aerosol and contact, that should be enough, along with face shield, gloves, masks, and headgear. As far as the issue of and gown, obviously, as far as the issue of availability or utilization, there should be prudent utilization of all PPEs, because you will be coming in and coming out of contact with the patient a number of times in a day. And as far as using the PPE, if you come out and come in 4 times, that doesn't mean you perhaps use 4 N95 masks. It's better that you use one mask and plan it in a manner so that there is prudent use of available resources. Secondly, as far as testing a febrile patient is concerned, ICMR has provided guidelines for testing with antibody as well as with RT-PCR based tests. As clinicians, you are best placed to understand that not all fever is COVID, but with fever patients, you have to remain aware. You have to take a history. You have to figure out if there is a high risk exposure history, for example, traveler to a known case, or originating from a case from an area where there are multiple cases which have been reported. And those kinds of clinical discretions may be applied for utilization of diagnostic tests.
Okay, one common suggestion and common query is we have included hydroxychloroquine as a prophylaxis for healthcare providers who are who are in close contact and taking care of this COVID-19 patients. The only thing is our suggestion by some of the members is, can we include hydroxychloroquine for a pregnant woman more than 36 weeks for prophylaxis, because in when they are having malaria, we are routinely prescribing a chloroquine and it is not harmful. One more thing, if they there is no side, if they are not if it is not contraindicated in that particular lady, pregnant lady, can it be included in the ICMR recommendation, pregnant lady more than 36 weeks prophylaxis hydroxychloroquine, so that when they are asymptomatic carrier patients, when they are reaching to us for delivery, we can save other patients, her relatives, as well as healthcare providers.
So, with respect to hydroxychloroquine prophylaxis, there is a very narrow recommendation provided by ICMR, which directs how it should be used for prophylactic therapy in healthcare workers. Right now, until better data or evidence becomes available, it would be better to stick to that prophylaxis recommendation and not expand beyond that.
Yeah, this is just suggestion. We will stick to the recommendation of ICMR, but this is one suggestion from so many colleges also, and they are routinely practicing giving chloroquine to their patients. In spite of before this COVID-19 infection, also it is a tradition at some of the places. So this is the suggestion from those medical colleges which I am conveying and forwarding it to you, and they are asking if it is not harmful. We are using it since so many years, and can we use? This is the query they are asking us. So if possible, just it is request that just we can go through it if it is in any study, and if you require, we can use it. So this is the just suggestion I am passing it to you.
Sir, thank
One
you for
more
your
is,
suggestion.
huh?
Thank you for your suggestion, sir. But at one thing we need to remember that the primary reason was that it has been recommended for healthcare providers who are in sort of extra risk, and until and unless we have better data, if we start prescribing HCQ for anybody and everybody, then it is going to add to the shortage. So I think for now we should adhere to the prophylaxis guidelines and wait until better data on its effectiveness becomes available.
We all will stick to the recommendation by you and Government of India. There is this is just suggestion, and we will
Thank you,
stick to
sir.
the recommendation.
Thank you, sir.
Is there something called herd immunity, and do you think that there is any hope for healthcare provider to be protected by herd immunity? How much time it may take once is infected or in the community for herd immunity?
Thank you. This is a very interesting question again, because there is a herd immunity effect which is expected once a certain proportion of people get infected and raise a protective immunity against the pathogen. However, it would not be very prudent to wait for that proportion to get infected, because we would want to keep the number of sick people under a certain limit that can be managed by our healthcare system, resources available to us. Secondly, even if herd immunity kicks in, it's going to take a certain number of weeks or months to happen, because it will have to accrue that number of immune patients within the population. Till then, our healthcare providers are going to be continued, particularly those who are taking care of COVID-19 patients. They're going to continue being exposed to a very high risk group. So that way, I think we should not immediately rely on herd immunity to protect our healthcare workers. We should provide them with the protective equipment, and if required, the prophylaxis as prescribed or as recommended to prevent them from getting infections in the days ahead.
Last one question to you is, at present there is no community spread. It's a good sign for us, but if community spread occurs, then how to protect pregnant women and healthcare provider? What extra precaution they should take?
So with respect to preventive strategies, they're going to be same for healthcare workers. We have to be vigilant. We have to be protected. We need to remain very careful of our basic hand washing, our basic hygiene routines. As far as pregnant women are concerned, the theory will remain the same. They have to be protected against exposure. And if they become symptomatic, they have to be immediately tested and managed. Um, Considering the fact that you are thinking about this from so far ahead is a very positive sign. That means that we are starting to get prepared clinically to deal with any fallouts were they to happen in the next few days to weeks ahead of us. And I think it would be good for all physicians taking care of pregnant women to keep this special condition in their mind when they're considering the clinical picture as a whole.
Is there
Okay,
any?
Foxy has started its national registry for pregnant women with COVID-19. If it can be useful, helpful to ICMR or Government of India for making any policy, we are always there. We are ready to share it with you, and we have also sent on mail to you. If possible, if you get time, please go through it. And if can we establish some way through which, if any suggestion, if Foxy wants to convey any suggestion, we can convey it to you. We have prepared our GCPR also. It is also sent to you. So whatever the documents we are preparing or whatever the suggestions we have later on after this meeting also, can we, there is some way we can, through which we can reach to you or send it to you?
Yes, there are two parts to your question. The first part is about the patient registry. This is definitely a very helpful step forward, particularly because it will help us understand the natural history of COVID-19 in a very special population, which is pregnant women. So this is obviously a very valuable work that you have started, and I would like to thank Foxy for initiating this work. For sharing the data, it can be provided with the research team of the rapid response team under the COVID-19 group. You can access the whole list of rapid response team members from the ICMR website by going to the COVID-19 page and looking at the RRT, rapid response team. There's a bar which says rapid response team. If you click on it, a total list and contact details of all the relevant members come out. So you can reach out to the research team, you can reach out to the diagnostics team, you can reach out to the other different team members to sort of share your information, share your data, or share your suggestions. As far as this is concerned, I will also take the information regarding the registry to Dr. Ganga Khedkar, and I will intimate him that you have emailed and reached out to him as well. And I think he's always very approachable about all these issues, and he remains fully committed to fight COVID-19 in India on behalf of its people. So I think these are very good suggestions, and these can be taken forward that way.
So we are very much thankful to all of you, Dr. Gangaram Khedkar. You all are doing excellent work and you are taking care of our country. So we are thankful to all of you, your team at ICMR, and we hope that we will continue our liaison collaborative work regularly to save our pregnant women and save our country. We are always there at any time if you need. We are always there. Consider us with you only. And thanks a lot. Thank you very much for sparing time and coming here.
Thank you so much for having me, and thank you especially to all of you for taking care of one of the most important population groups in our communities. Thank you so much.
Thank you.
Hello? Yeah. We'll go on to the next question now.
Yes.
We will take Dr. Ajit first. Dr. Ajit, we have heard you have patients of COVID-19 with pregnancy. How many such patients do you have? And at what gestational age? Did they have any history of travel, occupation, crowd, and cluster? Did you do their test or were they admitted with a positive report? Do any of the patients have any comorbidity? Are they in quarantine, isolation, or hospitalized? And how do you counsel the family and the staff looking after them? Dr. Ajit, do we have you there? Can you hear me?
Dr. Ajit, please unmute your mic.
Dr. Ajit, can you hear me?
Yeah, okay. Can you hear me?
Yes, we can.
Oh, okay. Um, Thank you, Dr. Alpesh and Dr. Atul, for including me in this panel. Actually, we
Sir,
have
we
five
are thankful
cases.
to you. Sir, we are thankful to you.
Yeah, thank you. We have five cases. The first case, I'll go in the chronological order. The first case, actually, she came at 32 weeks of pregnancy. She was a case of previous cesarean section, and she contacted her husband became positive because of he's a Gulf attorney, and she had fever and sore throat, and found positive on this 21st March. Then actually we treated her with oseltamivir because in any pregnant lady in the third trimester with some respiratory infection, we start oseltamivir, and this patient was put on oseltamivir, and this patient result came as positive. Actually, we put her on this HCQ also, and she became negative. And actually, we discharged the patient 1 week back. And she is now in the home isolation. She is now 34 weeks of pregnancy. The second patient is actually 38 weeks pregnant lady. She was asymptomatic, and she came here because of the positive result. The test was done because her husband became positive. Again, a Gulf returnee. And actually, I have to say that I have to do a cesarean section today morning for her because of a abnormal NST and abnormal ultrasound report. And today morning we did an emergency cesarean section for her. She's also became negative actually after the treatment with SCQ. I don't know whether it is SCQ or the natural history that the reason. And the third case, actually, she is a 14 weeks pregnant lady. She got the infection from her mother-in-law and the sister. Husband is negative, mother-in-law and sister are positive. And again, she is also treated with SCQ. That is our policy in Kerala. Any patient with a positive infection, even asymptomatic, the state government policy is to put her on SCQ for 5 days. So she became negative, and she actually we discharged the patient also. She's in the home isolation now. Then again, we have two more patients, 13 weeks and 9 weeks. Again, both are positive because of the husband positivity. And again, they are also treated with SCQ for 5 days.
So, Dr. Ajit,
Yeah.
when you decide to give HCQ and when do you decide to give oseltamivir, that is Tamiflu, or do you always give a combination of all the drugs?
No, not at all. We start with SCQ only, but if there is any respiratory infection, we don't know whether it's any associated H1 infection, actually, which is more dangerous for the pregnant lady. So that if there is a respiratory infection, that naturally we give oseltamivir.
And none of your patients had any comorbidity like diabetes or hypertension, and all are young patients?
No patient.
All are young patients, right?
Yeah, healthy patients.
And how do you talk to the family and your staff? How do you counsel them? How do you gear up the staff for delivery or surgery? You said you did a cesarean this morning, and do you have enough PPEs with you?
Actually, we have enough PPE in the hospital, but again, we don't know anytime it may get depleted. So we are very careful in using PPE. Actually, we have a COVID team that includes the residents of surgery, medicine, all these things, even the non-clinical subjects. Actually, they will be going to the patient's room and taking rounds. And we don't usually, again, every day go to the room. We'll preserve the PPE. If there is any emergency, any indication, any obstetric indication, say if the patient says that the fetal movement is less or the BP is high or any particular problem, then only the obstetricians go and see the patient. Otherwise, the common residents will be taking the rounds. So we can save the PPE in that way. Again, when we do the cesarean section, again, even the person who is transporting the patient, everything they have to use the PPE. And in our cesarean section team, actually, we had 7 people, 1 assistant, 1 doctor assistant, 1 nurse assistant, then the 2 anesthesia people. So actually, we used 7 PPE for today's morning cesarean section.
And you have a dedicated OT and labor room for COVID patients?
Yeah, we have a dedicated. Unfortunately, the requisite is that there should be a negative pressure, but that is not available. That is very difficult to create again, even the Western countries is not available. So otherwise, we have a dedicated OT and a dedicated labor room also for this.
So these
The problem with the prolonged monitoring the patient is actually it's very difficult to monitor the patient for a long period with the PPE on. So I have to say that there should be a low threshold to do a cesarean section. It is not an indication to do a cesarean section, but when you think that it's a prolonged labor, and if you think that it will end up in an emergency cesarean section, better do elective cesarean section when everybody is around.
So you said your residents go and take rounds. So what kind of protective gear do they wear when they go for rounds?
They wear the PPE, the full PPE they wear. When you go to the room, we have special rooms for these patients. So they wear the full PPE and then only go and see the patient.
So when they see these patients and use PPE, are these PPEs reused or do you discard them?
Discard it.
So after every use, so for example,
Yeah.
if a patient sees the patient every morning, so every morning we are consuming one PPE.
Actually, we need only one PPE because only if it is a critical patients, we need to continuously be there in the room. Otherwise, we can a single PPE. They can all COVID positive patients. They can go to with a single PPE.
Okay. And what about family members and your staff? Did you have to train your staff specially for this? And what kind?
Yeah, we have trained them. This special training we have given how to wear the PPE, how to protect themselves, everything. Even the reception, everything, they don't be wearing the PPE. They will be wearing the N95 mask. That is all thing they do. And again, the frequent the hand washing, the use of soap, the social distancing, all these things are.
How do you sterilize the operation theater after surgery? And what care of instruments is taken?
Yeah, there is a special bleach solution to clean everything. And again, we fumigate it also because it's an aerosol spread.
Okay, so you fumigate with the fumigating solution or you use chlorine or sodium hypochlorite?
Yeah.
Okay. Thank you so much, Dr. Ajit. I think we are very fortunate to have people like you who are managing these COVID patients and, continuously helping the country and our special population. And I hope we have more people like you.
Yeah, I'm surprised that out of 10 patients, five of the patients are from our institution. About 50% of patients. Yeah.
I'm sure there are a lot many which we do not know, Dr. Ajit, but I think your number.
Dr. Ajit, I would like to know, you have mentioned all 5 patients have history of contact.
Yeah.
Hello.
We have a
and out of these 5, 2 patients turn to be now cured also. They are negative. The reports are. So within how many days this report become negative?
Actually, every 5 days we do the test. After the first positive test, after 5 days we do the test. If it is again positive, again after 5 days we do the test. If it is negative, again we do the test after 48 hours. 2 tests negative means it is a negative. We consider it as a test negative.
Okay. And when patient is admitted at your place, before you perform cesarean section, for how many days she was with you?
Actually, this patient was with us for the last 10 days. She was admitted on exactly on 27/3. She was admitted, and actually now the 2 weeks time, she was in the hospital.
So have you monitor fetal monitoring was done in this patient with FHS Tetho or with CTG?
Fetal monitoring, we do the CTG, but this patient actually what we do is we don't go to the room. Actually, we phone the room. We ask about her general condition, fetal movements, everything. Everything is normal, and a resident will take the rounds. May not be a OBG resident, maybe the surgery, or sometimes it may be a pathology resident who goes and see the patient. Again, it's very difficult to hear the effects with a stethoscope. So at least every twice a week do the NST, CTG.
And you have a dedicated NST machine for the COVID patients?
Yeah, dedicated NST machine. A separate NST machine, a separate labor room, labor suite. the NA, this neonatal care unit, everything is there.
Dr. Ajit, before moving to next, Dr. Nirja, would you like to share any experience? Any special comment or any experience you would want to share?
I think we have to consider giving HCQ because it's a good wonder drug. We don't have to wait for the evidence to come because definitely it will reduce the viremia. Even the first trimester, I think reduction of the viremia may help in reduce the chance of teratogenicity. The third trimester, again, the new studies have shown that about 3 reports of baby getting IgM positive. That means there is a chance of intra infection. That also we can reduce by giving HCQS. I think we have to consider giving HCQS. Definitely we have to follow the ICMR, but we have to consider it. We cannot wait for the evidence to come in this case.
Thank you very much for your clear message. Thank you, Dr. Ajit.
Thank you. Thank you.
Thank you. Please stay with us for the question answer session. Huh? Yeah. Dr. Nirja.
Good afternoon.
Good afternoon. Dr. Nirja, we came to know that first cesarean section on COVID-19 mother was performed at AIIMS Delhi in your unit. So what made you test the patient for COVID-19, or did she come to you after she had a positive test report? And why did you decide for cesarean section? Any particular reason, or it was a wish of a patient?
So this patient was our own one senior resident's wife, and he had been having symptoms off and on for almost a month when he finally presented and got tested and was found to be positive. So she was tested for that reason. She was asymptomatic, and she was, she reported to us in a sense. She was our own patient, but she had not come for checkup for 4 weeks. And now she was 38 weeks and 6 days, so almost 39 weeks gestation. Second gravida, previous normal delivery. Then what should we do? Should we have, now that she has come positive, should we now proceed to act? Should we wait? Should we let her have a normal delivery? Should we do a cesarean? So all these questions were coming in our minds, and we had already been working quite intensively in this preparation that we never know. We didn't really expect that we would be faced with the first one, but we were prepared. We had made our SOPs after very careful consideration and several meetings of the faculty with the various guidelines, including our wonderfully done FOXI guidelines, international guidelines, everything. We had made our SOP. We had identified the place because that was a lot of problem. Our labor room is not terribly spacious, and the AHU was a big stumbling block because it was common with the NICU and how to make those drowning areas, doffing areas, and that whole flow to the microbiologist's satisfaction. So finally, we had identified our own OPD, which was now closed, to be the right place to do all this. And we were ready since the prior week itself with dry runs and everything done. So to that extent, we were not caught unawares. And so after discussing these various aspects, we had made our COVID teams who would be on call, and Dr. Rajesh Kumari from my department was the one that week. So then she went in to examine the patient in PP, and it was found that she had an oblique lie. And the husband, this wife, and his brother was also positive. They were all admitted in the different rooms in that isolation ward, which had been made for this purpose. So it was discussed with him also and with her also. And it was also considered that she's asymptomatic. She's in that way quite at low risk. But tomorrow, if she also develops symptoms, then she may be at a higher risk herself as well as her baby and so many things. So everything done, the family said that they would like to go for the cesarean on the same day. So she was not fasting at that time. So we observed the 6-hour fast. And then we transferred her to our that area which is constructed with a proper corridor identified for the movement with minimum contamination issue and all that. And we did this cesarean under spinal anesthesia. And the baby was good. Mild transient tachypnea of the newborn was there. And she was observed in the same area for 2 hours. And then the anesthetist accompanied her back to her isolation ward, and she was there. And that question was coming about how to monitor. And also after that, the next morning, one resident has gone in with the PPE to see the patient, remove her catheter, change her dressing. And after that, we did not really go in ourselves. It was video conferencing. Of course, there was one person dedicated, as Dr. Ajit has pointed out, one resident is there for the area. That is, he is seeing the patient, but we were asking her on video conference and getting her to take a picture of her stitch line and send it to us, convey the comments. And also after that, nobody really had to go in till yesterday, when again one senior resident has gone in to remove her stitches. So minimum use of PPE, and PPE has to be used according to the level. So we do think we had a little bit more being the first case, but we had 2 obstetrician, 2 anesthetists, 1 pediatrician, 2 nurses, 2 OT technicians also. And then we had the cleaning and all that assistance, that is separate. But they have all got the different levels of PPEs. So who is washed up has a different level of PPE as compared to the nurse on the floor, as compared to the person who is just outside as a runner, because communication becomes a challenge. Once they are in the PPE inside, they cannot communicate. So we were watching from the distance, because the room was on one side and the baby resuscitation was across the corridor. So we were waiting to see from there that when the baby is taken, we will know that the baby is out, because it is too far even to hear the baby's cry. But then we had this runner person to, communicate in between. It is so hot inside the PPE, then senior resident got completely suffocated after some time and was collapsing. So we said, okay, de-scrub, do you want someone else? One was sitting in standby. The first one we had no experience to go with also. But yes, broadly speaking, I think every center, every facility needs to be prepared. They need to know when a suspect comes, where will we keep? When a confirmed case comes, where will we keep? What will we do? I think that is absolutely need of the hour.
Yeah, thank you very much for the clear message that every facility needs to be ready, to be prepared. And as all the family members were having COVID-19 infection, so you might not be having any problem in counseling with the family members, but how you prepared your staff member? Are they ready for that, or you have to
I want to add one point, that family was in Aligarh. He was wanting to send her back there, but because of lockdown, he couldn't send her. So we had absolutely nobody ready over there to look after. And our social worker had to even arrange the clothes for the baby, the diapers, the little things, because there was nobody there to help the mother. So a lot of support needs to be given there. But regarding I think we have been going through this whole preparation. All our doctors, all the nurses, all technicians, and even the cleaning assistants have been put through the training for the donning of the PPEs and all the importance of all these things. So all trained personnel already are there. Mock drills had already been done with these people. And there were concerns, of course, on that day. There were people saying, now I have washed up in this one, so can I go home? But then we explained to them that you are in PPE, you are the most protected. Because right now, of course, it was the first case we had adequate PPEs. There was no problem at all. Only the point is now coming, like this morning, we had a suspect who has delivered. Now, she has no history of contact. She's an ITP patient who was getting repeated transfusions. Hemoglobin was low, her platelets were low, and preterm, she has gone in labor and she has delivered. And she was desaturating. She even arrested on the table. So she was resuscitated, intubated, baby is fine. She is in the ICU, but otherwise stable. Now, the big question is that was it because of her underlying condition, or is it because of the COVID? Now the nasal swab has been sent and it is going to come now, the report at 8 p.m. And now this entire team is understandably on tenterhooks. Is it going to be positive or negative? So the problem, I think, is more in the case where it is happening in an unexpected situation rather than when you are fully prepared for a positive.
But in our smaller setups, there will be always unexpected conditions.
Dr.
So what I am now suggesting to everybody is that we should restrict the number of people to the minimum, and we should try and see that they have the best opportunity. I'm recommending to everybody to wear the gumboots in the labor room as well as to try where possible to use the impervious gowns, so that it is a minimum exposure to the minimum number of people. And even in the routine, let us avoid unnecessarily rounds, unnecessary confrontation, and try and do more and more of video chats and chats with patients, even as a routine. I think that is what we can do as what we can call universal precautions in this condition.
And last question, Dr. Nirja, did you anticipate or predict any complication, any problem during the surgery? Suppose it's good for your fortunate patient did not have any problem, but suppose this patient have postpartum hemorrhage during cesarean section, any such complication? Did you
Yes,
prepare
absolutely.
any?
Even arranging the blood, because now we had to arrange the blood once she reached this facility, because just one person to wear PPE to change or what to do and all those things. And we did, so we made sure that it was a person with reasonable seniority who would be able to tackle and not lose cool and be, she was, I have to compliment Dr. Rajesh that she was very positive about the whole thing. And her husband himself being a pulmonary medicine person, I think it helped that she was completely understanding of the disease, always, telling other people who are worried that you have to understand it and go accordingly. And have your head on your shoulders, not lose your cool. And we did have one more person, Dr. Garima was there in her scrubs, ready to go in, but still it takes time to don the PPE. So we were just telling Rajesh, if anything happens, you please just keep it all pressed and just call and don't get panicky, don't worry. But we were all confident that she will not worry about it. In fact, the lights went out at that time, just as the baby was taken out, and it is a makeshift facility. So we had to bring in the torches. But it was daytime, so there was a lot of natural light also, luckily, at that time. So, so many things had not yet even been done for that facility, but by grace of God, and it all went quite well.
And I hope AC was not on.
No, AC was not kept on because of this problem, about needing to maintain negative suction. No AC there. That's part of the problem, I suppose.
So, Dr. Nirja, congratulations for performing in your unit, performing the first cesarean section on first COVID mother in India, and you are now the we can say other will also be inspired by you, and they will learn all these things. Thank you very much for the clear messages, and thank you very much for taking the decision in time before she has she develop any symptoms. You perform cesarean section. So.
Yes, and I think Dr. Garima, Dr. Garima, Dr. Ramesh Agarwal, our neonatologist, have worked a lot on the guidelines, and anybody needs help, we can definitely have them help.
So we hope that you will also be helpful in giving data in this our registry, sure. And we will work together. AIMS and HOXI will also be work together collaboratively sure. For COVID-19 infections. Thank you very much, and once again, congratulations for managing the patient well in time.
Thank you.
So we'll move on to Dr. Ram Chahar now. Good afternoon, sir. Are you there?
Good afternoon, sir. I'm here.
Yeah, sorry to keep you waiting. I thought we'll have the clinical people talk first so that we can go on to the universal precautions and the rest of the care that needs to be taken.
Yes.
Dr. Ram, FOXI believes that breastfeeding should be allowed, but RCOG, ACOG, and the neonatology associations have different recommendations. What is the stand of WHO and how do you justify them? Can WHO play any role in the care of the healthcare provider? Because as you heard Dr. Nirja say that they had an unexpected patient who came in and delivered. And is WHO recommending that till we have better modalities of testing, like the IgG and the IgM rapid kit, every delivery should be considered as a suspect on a PPE, should be downed by all the healthcare providers, giving this facility to our women because they are precious. Pregnancy is a physiology, and we cannot avoid or neglect them at any stage. And once you answer these, we'll come to the other two questions.
Yeah, thank you so much, sir, for giving me this opportunity to provide some more information about the ongoing work that the WHO has given and all the technical inputs which have been created by the whole team at the headquarters, the regional office and the country office levels. So, so I will take the first question that about the importance of the breastfeeding and where do we stand with respect to the promotion of the breastfeeding or not. Sir, I would say that, you know, there is no two thoughts about the whole thing, that the breastfeeding provides the protection for the newborn against the morbidity and death, especially in the post-neonatal period and throughout the infancy and the childhood. Also, we have to understand that whatever the current evidences that have come out from the studies in the China and the rest of the world, none of them have indicated any evidence or any show of vertical transmission of the infection from a mother to child, as well as any evidence of or any indication of its transmission through the breast milk. So is breastfeeding recommended by WHO? Absolutely. The protective effect, you know, I mean, we need not go preach again to the choir, because everybody here, I'm firm believer that, you know, we all know about the importance of the breastfeeding in the mothers, especially in the Indian context. But just, you know, just a parting thought on this will be that the protective effect is particularly strong against the infectious diseases that are prevented through both the direct transmission of the acquired antibodies from the mothers and also the anti-infective factors and the long-lasting transfer of the immunologic competence and the memory. So I would say that the breastfeeding is the one recommendation that is a recommended recommendation on the part of the WHO, and it stands you know, applicable even in the current circumstances. The challenge in the current scenario is that how to implement this recommendation, because on the one side we are saying that there is a need to maintain the social distancing. So what to do? I think at this point of time, our healthcare workers also need to understand that there is a need to teach the mother and the families about what are all the infection prevention control measures that need to be followed, and also the respiratory hygiene. So I think that becomes part of the breastfeeding counseling that our health workers will need to provide to the pregnant mothers as and when they are coming for the delivery in the hospitals. And also the counseling about, you know, how to maintain the social distancing, not to allow too much of mingling within the hospital and in the household, and you know, the frequent washing of the hands. So if these recommendations are being applied to the mothers in terms of maintaining respiratory hygiene, as well as necessary precautions for infection prevention and control, the breastfeeding still remains one of the most important and the easily available intervention, which will help us in reducing the post-neonatal complications, as well as in reduction of the morbidity in the newborns. So, so I would say that, you know, that is the recommendation that still stands. There are specific conditions, the medical conditions, where alternates for the breastfeeding are recommended by the WHO. But as per current evidences, COVID-19 is not included in the list of those recommendations, where we have to look for alternate feeding sources for the newborns in the mothers. So that is the first part of the response. Coming to the role that the WHO is playing in the care of the healthcare providers. Sir, during the discussions today, again and again, the importance of the infection prevention and the control has come up repeated number of times, the need for having appropriate donning of the personal protective equipments, as well as, you know, having an appropriate mix of contact as well as social distancing. Healthcare workers in the current situation are, you know, from coming from the WHO, I would say that we are well aware about the different hazards and the dangers which our healthcare workforce is currently facing. We are seeing the challenges in terms of increased workload that the health workers are subjected to. There are long working hours associated with physiological and as well as psychological distress. We are not able to provide them enough opportunities to mingle with their families. There is occupational burnout, fatigue, stigma, and psychological violence also on the part of the healthcare workforce. So there is a complete list of technical documents which the WHO has developed, starting with the rights and the responsibilities of the health workers, as a health worker, what are the rights that a health worker has in a hospital, in a facility, and what are the responsibilities they are attributable to them, including the measures needed to protect the occupational safety and health of the health workers. What are the responsibilities of the facility in charges in terms of those? The second question that came up was that, is there any guidance available on risk assessment of the health workers and its management? WHO has come up with a tool that can be used by the healthcare facilities that have either cared for or admitted patients with COVID-19 suspects. This is to be completed for all the healthcare workers that have been exposed to a confirmed case, and on the basis of the level of exposure, the recommendations are also provided for the appropriate management of these healthcare workers. So we are aware that, the healthcare workers are our first line of defense against the COVID-19. And if we are able to take good care of our healthcare workers, they will be, the best bet against the current situation. So I would request through this forum that everybody would, it would be good if more circulation is done for these assessment tools within the facilities and through your network, so that all the treating hospitals are aware about these tools. These are just glimpses or the snippets of the different tools that I have provided. Apart from that, there is a range of technical documents that have been developed addressing the different scenario. The next I would share about is the risk communication strategies that have been developed for use in the healthcare, for the healthcare workers in the hospitals. That is also a very good resource material that is available with us, and it is available for general use. Everybody can just access the site, or I will be very happy to share all the contents with you for use among the peers and in the hospitals in India, so that everybody is aware about, we are able to take care of the fear and the misplaced notions which are associated with the COVID-19, especially among the healthcare workers. So I think that is also some of the things that we are done from our side.
Is WHO...
So the last thing, I think there is also a need to have some sort of FAQs for the healthcare providers, which takes care of their, different scenarios which come up during their practice in managing the COVID-19 cases. So the WHO has also developed an FAQ section where we can, they can share their responses and also provide, also get answers to the commonly asked questions while managing the cases. Sir.
But Dr. Ram, 2/3 of our deliveries take place in the private nursing home. And I'm sure most of the people listening to us are from smaller private setups where there is only one labor room, one theater, and they cannot dedicate a labor room or an operation theater for COVID patients. What is your message to them? Do they take universal precautions for all? Because I've worn the PPE kit twice in the last 3 days, and in humid weathers, you really sweat so much, and the delivery takes about 2 to 3 hours. I think I would be dehydrated at the end of it.
And at the same time, there is a great shortage of PPE also in our country.
Sir, it is
so looking to both the things, you just guide all our small nursing home practitioners.
I would say that, sir, we are kind of caught in a situation where on the one side we have a cliff, and on the other side we have the valley. So in the current situation, I would, sir, it's better that we look at creating opportunities where the PPE becomes the major point of protection for our healthcare workers. I understand it is a very difficult situation. I would recommend, sir, that the small healthcare organizations which are major source of, I would say, the interaction in the today's call. There is a WHO document which has been developed about what is the level of the different PPE which is required for handling the cases. So it is not like you need to have the complete set of PPE at all points of interaction with the pregnant women during the admission. So that would be a good starting point. But we will require to have, sir, we need to have more advocacy for creating the PPEs within the country. There is no two thoughts about it. My recommendation would be that we require to have the PPEs in the place for managing the cases.
Thank you so much, Dr. Chair.
In our GCPR also, we have mentioned 3 levels of PPE category, where which PPE should be where. Even Dr. Girja has also mentioned for the appropriate PPE for appropriate place and case. So we recommend appropriate PPE, but of course we have to do recommendation. We have to do at other level also for providing these PPEs, making it available.
Dr. Ram, your last question. We hope earnestly that in this COVID-19 pandemic, the MTP and abortion services and the contraception care on counseling of our patients does not suffer in India and the rest of the world. Do you have a message for us?
Sir, it is going to be a very challenging situation because across the country, the most important the most important factor in ensuring utilization of the contraceptive services is ensuring access to them. So the access part is something which we are all finding it very challenging in the current circumstances. The reproductive health services have been included as one of the essential services to be maintained during the COVID outbreak. As per WHO recommendations, WHO had come up with a list of, what all the essential services the country should look at and recommend. So I believe we will be having some challenges in creating and managing the supply chain for the contraceptive services in the country, as well as for the MTP and the post-abortion services within the country. But over a period of time, I would say within the next month or so, we will be in a better position than we are today. I totally agree that this is going to be a big challenge, and it is also going to be a big burden for our health systems if we are not able to address this issue, because failure to provide contraception creates, excess burden over our already stressed health systems down the line. So right now, sir, we do not have any specific answer to say that the contraceptive services are going to be affected in adverse manner, but we understand that the access part is going to be challenged, and that will create a lot of difficulties for everyone, both the service providers as well as for the service seekers in the coming quarter.
You said we will be in a better position after a month. In Hindi, I should say, aapke muh mein ghee shakkar.
Thank you.
Yeah, thank you very much for very clear messages, Dr. Ram. I think we'll move on to the next panelist. We'll take Dr.
Rajesh Matre.
Okay, Dr. Rajesh Matre. Rajesh is the HOD of the Navi Mumbai Municipal Hospital. Dr. Rajesh, please tell us about your experience of the patient that you performed the cesarean on in Mumbai, probably the first documented cesarean in Mumbai. Did the patient come to you with a positive report, and how did you look after the patient?
Firstly, I thank Foxy. I hope everybody can hear me.
Yes, absolutely.
Yes.
Firstly, I thank Foxy, Dr. Alpesh Gandhi, Dr. Atul Ganatra, and other office bearers for inviting me, honoring me to this session and letting me share my experience. This patient of mine come to my hospital already tested positive. She had been to the other 2 medical colleges in and around Navi Mumbai. She was tested positive at 2 different places, one at private lab and other one at government setup. This patient came to us. She was gravida 2, para 1 with previous LSCS with 40 weeks of gestation, and USG was suggestive of severe oligohydramnios, AFI of say 3 to 4. And so as she was 40 weeks, I thought I will go ahead with the cesarean section for her. An elective LSCS. We admitted her on 5th of this month, April, and she was undertaken for section on 6th of April.
So did you have enough preparatory time? How did you train your staff? Did you have enough PPEs? And
yeah,
and the rest of the team?
Our hospital is a Navi Mumbai Municipal Corporation General Hospital, the 300-bedded hospital, and our honorable commissioner has taken decision to convert this hospital into a COVID dedicated hospital.
Brilliant.
So
So,
it's 300 bedded hospital is turned into a 120 bedded COVID dedicated hospital.
so
But
Dr. Rajesh, I want to know, when it is a COVID dedicated hospital,
yeah,
do you continue with the normal routine, not, or only
no,
COVID-19 patients?
it's only COVID-19 patients or presumptive COVID-19 patients are admitted to this hospital. They're kept under isolation as this patient was already tested positive at two places.
So
It
you are
was
not accepting a patient who is not having COVID-19.
No, we have got, this is our main hospital. We have got centers in the other suburbs of the Navi Mumbai. Those patients are catering over the normal patients and who are presumptive or definitive COVID-19 patients. They come to our hospital. May it be a labor patients, may it be a general uh, patients.
So you are a dedicated COVID-19 doctor.
I hope.
So uh, how many doctors were there? How many provider were there in the OT?
So basically, I have prepared 6 people for the surgery, but I allowed only 4 of us to be entered into the OT. One of them was myself, other one was anesthetist, one staff nurse, and one housekeeping worker. Only 4 of us, and other two were donned in PPE, but they are kept outside the operation theater. My
So one
main
question is, we are discussing for the donning and PP for us,
Yeah.
but tell us something for patient. Did you give mask to patient or something else? What precaution you took?
Yeah, patient was already admitted to our isolation ward previous day. She was given N95 mask all through her stay in the hospital. She was taken to the operation theater with N95 mask. Anesthetist induced her with spinal anesthesia because with GA, there are chances of spread or droplet infection is more. So anesthetist preferred giving a spinal anesthesia. My main aim was to quick in and quick out during the surgery. I being the senior most person, I took the challenge ki chalo I'll do the surgery and finish it off as quickly as possible, and there will be a less chances of people exposing to the virus. And I'm very proud I finished the section within 22 minutes, skin to skin, and everybody was out without any.
Oh, good. That's good.
You took
So
enough.
one thing I would like to ask is, this is not related to this particular COVID-19 cesarean section, but suppose a patient is, we are going to perform MTP, DNA, something like that.
Yeah.
Then also, so do you recommend N95 mask to the patient?
Uh, if the patient is complaining of any symptoms like cough, cold, or a fever, and she is a presumptive patient, you will definitely ask her to wear N95 mask, and all the person performing will take the universal precautions.
Okay. And how you manage this patient post-operatively?
Once the post-operative and once the suction was over, patient was again shifted to isolation ward. She was monitored by a general people, I mean the other residents from other branches and the staff nurses. Only the next day, one of my gynecologists with PPE donning went for her examination. The baby was kept away from her into isolation in NICU because we don't want baby to get infected because of the mother. And baby has been given express breast milk and whatever top milk, whatever she can give. I mean, we are not giving breast milk to her. Direct breast milk, we are avoiding direct breast milk.
Has the baby been tested as well?
Yeah, baby was tested on the third day. A baby is fortunately negative.
And what about the antiviral
Are you
drug?
going for second test?
For baby, yeah, on the 5th day of the surgery. Maybe tomorrow we'll send the baby for the second testing. And let me tell you one thing, just before starting this seminar, I received a call from a hospital saying ki the mother's test has come negative for the first time because after 14 days of the first positive test.
That's
Today
good.
she tested negative. So we'll send a second test after 24 to 48 hours. She comes negative, we'll discharge her and she will quarantine her for another 28 days at her home.
So when you are planning to discharge her?
If today her first test came negative, if you have a second test after 48 hours comes negative, then we are planning to discharge her.
Okay. And what medicines you have prescribed to her?
Routine antibiotic, what we are giving during the post-operatively, except we are avoided giving gentamicin or amikacin because they are renal toxic, and avoid giving diclofenac. We are giving her Monosafe and Metrogyl. You are giving her paracetamol as a painkiller, and we are given her HCQ from second day onward, 200 milligram BD for
I
14
think
days.
she was also having some cardiac problem.
Yeah, she was dextrocardiac.
So even though, of course, dextrocardia may not be a contraindication for hydroxychloroquine,
Yeah.
but did you suggest ECG before starting hydroxychloroquine?
Yeah. She ECG was done, that was normal, and her 2D echo also was done, that was also showing 65% of
Ejection fraction.
ejection fraction.
Fair enough. I think wonderful, Dr. Matre. That was a good decision. I think the patient is fortunate she came to you, and you are probably going to be the torch bearer of the COVID infection, cesarean section, at least in the city of Mumbai. And
All three are torch bearers. All three torch bearers are with us.
yeah.
First cesarean section, second cesarean section, and third cesarean section. All three.
Yeah. So
are present in our panel.
Move on to Dr. Nozar Shahryar. Dr. Shahryar was the Secretary General of FOXI. Good afternoon, sir.
Hi, good afternoon, Atul.
Hi. Your list of questions. Has the COVID infection affected your practice? What changes have you brought about in your practice? How are you managing the obstetrics? Message for practicing obstetricians, particularly those in the smaller nursing homes, message for the people who are listening to us on this panel. Most of them are probably from smaller nursing homes. Or comment on essential maternity services. And do you think it is essential for all of us to have PPEs during delivery and cesarean section?
So Atul, that's a lot of questions. So I shall just talk about the things that I have been speaking to Alpesh and you about. The COVID-19 pandemic has changed everything, and it's affected everyone's practice. And it has actually taken all the oxygen out of the room. In the 3-week lockdown that we've had in this country, we have probably had an estimated 2 million deliveries and childbirths. And you can imagine how much disruption has happened, particularly in the centers and the metros where this disease seems to have kind of taken center stage. Now I'll tell you about my practice. So my practice is in hospitals, and obviously I look after my patients in private clinics. So we have the public sector, we have our large hospitals, and we have our the backbone of maternity care in our country, which is the nursing homes and the private clinics. And I believe each one of them has been affected differently. So the first challenge that we faced was initially things were fine. Hospitals were gearing up. We will have to continue with obstetric care and maternity care, but we have to understand that as time passes, more and more hospitals are being exposed to patients who are COVID-19 positive. And as you know, at last count, a number of hospitals in Mumbai faced lockdown. Now, I can understand, I know there's everything being affected. There is CV is being affected and ischemic heart disease being affected. But if there's one thing that you cannot put off is all the patients who those hospitals were supposed to look after their obstetric care. And you can imagine what happens when a hospital shuts down. Even when the hospitals weren't shut down, you were struggling with staff, you were struggling with care. And actually, I did have an article in Governance Now where a journalist spoke to me about the problems we were facing. And you know that you face problems of staff because their families are petrified and they are so afraid that they will try and not let them go to work. We had problems with staff getting to work. And remember, I'm not just talking about staff of large hospitals, which get an exception under essential services. I'm talking about staff at doctors' clinics, consulting rooms, and small nursing homes who will be obviously, they don't stay on site and be difficult for them to get to work. And I know these are early days and we have to work most of these things out. Patients are finding it difficult to get around. So finally, what we did was, obviously we couldn't continue practice as usual. Antenatal care is something that's essential. If we don't have antenatal care, and there's only so much antenatal care you can do on a phone or on a video call. So we now, at least since the lockdown happened, continue to run a clinic twice a week. We've limited the number of patients we see to the ones who are absolutely essential and who must be seen. I mean, you can't miss the time of a dual marker anomaly scan or a 36-week examination because you need to make decisions. So we actually spend a lot of time deciding who comes. We are in communication with our patients. At this point, it breaks my heart, but no new patients and no gynecological conditions at the clinic. And at least we are keeping obstetric practice going. I can tell you, patients are so relieved and grateful when they find out that their obstetric practice is continuing unaffected. Now, in the last 2 days, two of the hospitals that I work at in Mumbai, and I shall not name them, have had confirmed cases of COVID-19, not in the maternity department, but we did have some staff members, including some in the maternity department, testing positive. And I can tell you that there is chaos. And I assume that all these thousands of people listening to us are getting multiple phone calls every day from their patients in their practice, whom they have made a commitment to look after, who are worried about, will the hospital still be open? Will I be looked after safely? Will you, doctor, be available? And what happens if you test positive for COVID-19? And you constantly have to be discussing with them, be honest, be transparent, and we go along. Have I delivered patients? Of course, I have delivered patients this week. And I delivered patients last week. And these are patients who are low-risk patients. So again, we've got to categorize patients into two. I believe someone asked about PPE. Well, our Foxy GCPR has said it so beautifully. The levels of personal protection and how you prepare are for patients who are suspected to have the disease or you have the disease. If you start using a PPE for 2 million women in 3 weeks in this country, it's going to be impossible. So let's not be unreasonable. Let's not be irrational. We have such clear guidelines organizations are giving us. I know there is panic. I know hospital administrations have knee-jerk reactions. Authorities have knee-jerk reactions. We got one directive saying, test every patient antenatally. Now that is irrational because I don't know when she's going to come in labor and deliver. And obviously, if you do a test for her, what validity does it have if she comes after 2 weeks? And if I do that test for my patient just because she can afford it, I'm denying someone else who needs this test. So let's not be irrational. Let's be wise at this point in time. First, look after yourself and follow all the procedures that we need to follow when looking after low-risk populations. Secondly, we prepared. Every patient in our clinic comes by appointment, so they get a phone call and a history is taken on phone. I've had patients of mine who had a history of coming from overseas, and we asked them to stay at home till that period of, I made it 21 days was over. I've had patients with fever and we managed them on phone, and we had to be quite sure that they came in because other patients were at stake. For a low-risk patient, we have to give her minimal antenatal care. You can't deny her that. For that low risk patient, we have to be reasonably safe for them and with us. Yes, I've been asking all my patients. I've had MTPs in the last 2 weeks, both medical and surprisingly, I do very few surgical induced abortions, but this time patients are so desperate not to come again that they prefer the surgical so they don't have to come back. You take precautions. Someone mentioned, of course, a patient should wear a mask. The person who's at greatest risk in our team is our anesthetist. So no patient should now be without a mask if they come into an OP, even if it be a low risk patient who's wearing a 3-ply surgical mask. Of course, we have got to take up care and we have to wear our visors. But do we have to wear full personal protection equipment for a patient who is not known to be high risk or who's not known to be diagnosed? I personally don't think so. So let's not lose balance. At the same time, I think that Foxy will make a recommendation. Alpesh has asked us to work on it, where we have to stress that obstetrics, I know it was said by the WHO, but I'm not seeing it on the ground. When you shut a hospital in Mumbai, and I can name at least 5 hospitals shut in Mumbai, there were patients registered to deliver there. Those patients now have nowhere to go because other hospitals are shutting their doors. I know this is a Mumbai problem at the moment because we are taking the bulk of the load presently, but it's soon going to start spreading to every metro and every city in this country. And we now have to take care that even if a hospital has a problem, and this is a multi-specialty hospital, so you have to have services going for your low-risk patients. These hospitals are large hospitals. They've stopped everything else, so there is a lot of place in the rest of it. So if I have a patient where I'm concerned who's an unregistered patient or who's a patient at risk, I have asked for delivering them in a secluded place by dedicating one operation theater to that work, because operation theaters have better filtration and safer enclosed environments. If there is a doubt, absolutely, completely suit up for being careful. But if there is a low-risk patient, protect your staff. Do not allow your staff to be used anywhere else in the hospital. This is happening now because the authorities are desperate. Protect your residents and your junior doctors because hospitals are diverting them to other responsibilities, and obstetrics has to go on. Keep your anesthetists who are working with you again for this work because it's as important as maintaining COVID-19 patients. And finally, constantly keep reassuring your patients. And maybe I'll make another recommendation here. We've got this fabulous GCPR from Foxy Alpesh. I think it's time that Foxy wrote something for laypersons. I think it's time we wrote something in simple people's language to tell them, be reassured. Maybe it could be a 3-pager or a 4-pager, telling them that when you're a low-risk patient, we are going to look after you. I tell my patients that it's a fluid situation. I don't know what will happen tomorrow, but I promise you that there will be an alternative plan for you if the hospital runs into trouble. I promise you there'll be an alternative plan for you if I run into trouble or a member of my team runs into trouble. And at this time, I am not talking about this amazing work with COVID positive patients. They are the tip of the iceberg. But let's not neglect those millions of women because of this disease, which is kind of just suppressing everything else. And my plea to our Foxy members is that we have a commitment. We are the champions of these women. Contraception, of course, it's going to be affected. There's no question. I mean, fortunately for us, chemist stores are still open, but chemist stores are running out of essentials. I know we are trying to say that it keeps getting supplied. I know that my daughter just called me and said, no baby products available. I know my patients in Bombay are saying baby products are no longer there because sometimes these things aren't considered essential. We have to wait for these chain supply lines to be set up, but we have to also tell women that besides the COVID-19 epidemic, the next most important thing to do is to look after the 27 million childbirths and the 16 million in 15 million induced abortions that will happen in India every year. Otherwise, we are looking to very dark times.
Will you have a lower threshold for cesarean section? And will you do a tubectomy
Yes.
on your patient?
Yes, I will have a lower threshold for cesarean sections, but I will still deliver patients vaginally. So I have had patients, in the last 2 weeks who had both C-sections and a normal delivery. But I can give you the example of a patient I delivered yesterday who was post-dated by 4 or 5 days and whose estimated fetal weight was 3.6 kilos, who weighed 110 kilos. In a normal situation, I would have waited or I would have induced. In this situation, I sat down and had a chat with them. We are also concerned as to what's going to happen to hospitals, and they opted for a planned C-section, and that's what we did yesterday. So the threshold is slightly lower, but please understand, as far as the patient is concerned, and even you are concerned, a vaginal delivery is actually more of an advantage because I want my patient out of hospital as soon as possible. There is no question that discharging a patient from hospital with a baby is much earlier if she's had a vaginal delivery than if she's had a C-section.
What about tubal sterilization?
A tubal sterilization, of course, if she wants, you know me, Atul, I have always believed that that's a decision women make. And I don't see why this should change anything else in our practice. I may not be doing too many tubal sterilizations because today you've got LARC and you've got patients with smaller families and stuff. But if a patient wants it at the time of surgery, of course I would do it. It wouldn't change the way I practiced medicine as long as I'm doing.
Is there any change of gear, your outfit, your clothing when you go to the patient now?
Yes, yes. So when I go to the patient, well, let's face it.
Are you wearing mask?
Yes, yes, I am. And Atul knows now I am because Atul is my PPE guru and all these things. So yes, we are. Yes, I've insisted that all my staff does. We didn't initially start off with that. Yes, I ask all my patients and their attendants to have it. Yes, there is a lot of social distancing, a lot less touching. I think that the sanitization and the washing has made a terrific difference. I think everyone listening here will tell you, we who are seeing patients are seeing fewer coughs and colds and infections than we ever saw before. So whatever's happening is affecting your common other illnesses. Otherwise, every second patient in our OPD had it. When I do the delivery, yes, eyewear, yes, a better quality mask if possible, obviously an N95 suit. Otherwise, mainly, I mean, someone said it before. If you can protect yourself, even in a low risk patient, from suddenly, from the patient's a cough or whatever else, if you're wearing your cap, your eyewear, your mask, your gloves, your gown, and maybe footwear which covers you well, I think you're pretty safe. In the operation theater, well, hospitals are doing it differently, but as of now, for the C-sections, they're giving us HIV kit. But you know what's bothering me, Atul? Hospitals, no matter what you do, will not have infinite supplies. And I told you about this the other day. A large hospital in Mumbai, infection control told everyone you got to wear N95 masks, and we all did for the delivery. And when I went back for the next delivery, they had run out of N95 masks. So we have to ration these things.
Yeah, Dr. Alpesh.
Thank you, Nozar, for a clear message. We have to look after with all 27 million births, and our primary concern is essential maternity services. Now let us move to a person who is sitting quietly since 1.5 hours. Dr. Parikshit.
Hi, sir.
We appreciate your patience, and I would like to know, as Nozar has mentioned, low risk patient and high risk patient. So would like to know something more about this low risk patient, how you would like to manage in your practice of this low risk patients, particularly for 4 things. One is visits, number of visits. Second is vaccination. Third is sonography. Fourth is steroid. And fifth, would you like to give Maxel to suspected or confirmed COVID-19 mother for taking care of fetal neuroprotection in preterm delivery? These 5 things, will you please enlighten?
Thank you, sir. I think once again, it's very important that we reiterate that obstetric care is essential medical service. And even though we are doing our best to minimize the number of visits that patients make to the hospital or to the clinic, we still continue to be in touch with them and we continue to care for them. Now, coming to the specific questions that you've put forth, I think in reference to this particular question, when we talk about low or high risk, it is to do with the obstetric risk factors rather than the COVID related risk factors. So considering a typical low risk antenatal kind of a profile, the minimum visits that I would be looking at is the one at 12 weeks, one at 18 or 19 weeks, and the third one would be somewhere between 32 and 36 weeks. Those are the three which I feel are probably the ones which we can't do without at the moment. One could always argue about ultrasound, that, well, ultrasound is not an emergency, and if there are no symptoms, you could just wait and watch and see how things evolve. But unfortunately, even though the risk of anomalies, the risk of abnormalities is only 1 or 2%, for the women that this happens to, it's 100%. So women look for that reassurance that everything is going well. They want to know how their pregnancies are proceeding, whether everything is pointing in the right direction. So that's the rationale of the 12, 18, 19 and the 32, 36 week visit. It's essentially a reassurance visit in low risk antenatal women. And those are the three that I wouldn't want to stop doing. As far as the vaccinations go, there's no change in the recommendations for antenatal women. So typically, what is recommended is the first tetanus toxoid injection, followed by, depending on what kind of healthcare profile this woman is following. If it's a public hospital, they get another tetanus toxoid. If they are in a center which is providing the Tdap, then they would have the second Tdap as scheduled. So no change in that as far as low risk antenatal patients are concerned. I'll tackle the other two questions first. The one about the steroids and magnesium sulfate. I think steroids, there's a bit of a confusion. They ran into some bad name as far as COVID is concerned, but those are steroids given as a form of therapy for the COVID infection. Those aren't the steroids that obstetricians give when there is a risk of preterm birth. So let's clearly distinguish these two things. The dose at which and the type of steroids that we give for maturing the fetus, the dexamethasone or betamethasone, is perfectly fine. Please go ahead and we should all use those wherever we think there is a risk of preterm birth. No problem with that. Same criteria to be applied. Magnesium sulfate, yes, again, the same criteria where I would suspect that there is going to be a preterm birth less than 32 to 34 weeks. That's where I would use magnesium sulfate. And if I were to take care of a COVID-19 mother in that kind of circumstances, I think I would recommend using magnesium sulfate in that situation as well. Now, the last bit which is left unanswered is how do we plan care for high-risk women in these kind of circumstances? And unfortunately, that's a place where we'll just not be able to skimp or save on the number of visits. At the moment, I think, of course, using all the reasonable precautions that have been talked about a number of times through the duration of this panel, I would still continue to want high-risk women to receive the same care as what I would have given them before the times of this pandemic. So I think with high-risk women, unfortunately, there's no abbreviated version of antenatal care that we can offer.
Parikshit, the last question is, will you mention something about the flu vaccine? Number one is flu vaccine. And yes. myself is believed that it may have some respiratory problem, depression or something. So in
Yes.
COVID-19 infected patient, is there any recommendation which clearly mention it can be given or it cannot be given?
No, there's no clear recommendation about magnesium sulfate use in COVID-19 mothers, but I suppose if there is any element of systemic illness or respiratory problems, then of course those women we keep away from drugs which have a potentially negative impact on the respiration. But in all others who are systemically okay, as we've seen, the experiences of the centers which have actually been dealing with COVID-19 positive women, the women seem to be systemically all right. None of them, fortunately, have run into any serious trouble as of now. So, given that scenario, I would be interested in recommending the magnesium sulfate. The second question was about the flu vaccine, and the recommendation as it stands is that yes, flu vaccine should be a part of our routine care, not only to antenatal women, but in general. So, considering the fact that influenza has a high risk in pregnant women, which is completely different from the coronavirus infection, yes, flu vaccine should be a recommendation as routine for pregnant women. Whether it provides them with any additional immunological properties to combat the corona, well, that's a matter of debate. No clear-cut answers there, sir.
So when you will give flu vaccine, 32 to 34 weeks?
28 to 32 weeks is what we generally do.
That is okay, but you have mentioned 3 visits. One is 12, 13 weeks, another is at...
at the last visit. Of course, in these times at the last visit, yeah.
Parikshit,
Yes, Atul.
a lot of questions about whether the healthcare provider should take prophylactic HCQ. You've been a part of the GCPR, and I think we sat in Black Tub Brains together. What is your message?
If you're not looking after COVID-19 patients, suspected or otherwise, that means I think that would be the message for 97% of or 99% of the clinicians who are there in the country at the moment looking after pregnant women. I think it is a completely irrational approach to start taking HCQS. First of all, we don't even know whether HCQS is an effective kind of a chemoprophylaxis. This is based on probably the lowest kind of grade of evidence that we have. The situation would be different if someone would actually be dealing with COVID-19 positive women. That's a different ballgame. Yes, then throw everything, including the kitchen sink at it. Take HCQS, it's fine. It's a safe drug, no doubt about it. But the other large, very vast majority of people who are not going to come into contact with suspected or proven COVID-19 mothers, I think it's probably not a rational message to give out to take HCQS.
What about ivermectin? There's some studies about
very rudimentary data at the moment on ivermectin, and again, not I don't think it's even been tested in even in a small cohort. So at the moment, we are keeping our eyes open on all the possible drugs which are coming in, including a host of different antivirals. But let's see where it goes in terms of more literature coming.
I think, Dr. Alpesh, shall we take some questions? There are more than 400 questions. I'm trying to take some of the more pertinent ones.
Yes. Please start.
This is now regarding the 3 torchbearers who have done cesarean sections. Did you all use electrosurgery during the cesarean section? Dr. Rajesh, Dr. Ajit, and Dr. Nirja, could you please answer this in a sentence? Because of aerosol spread, because laparoscopy has been stopped because of risk of aerosol spread in an asymptomatic carrier. A lot of us routinely use extensive electrosurgery when we open the abdomen, even for a cesarean section. Rajesh, are you there?
Yeah, I'm here. Yeah, I did use it.
Okay.
We don't use, and we didn't use any electrosurgery.
So no, you don't use it in.
You do not require, or you are not recommending?
Yeah, we didn't require it. We would have used it if we needed to, but we didn't require it, so we didn't use it.
So for the COVID pandemic, also you were not using electrosurgery.
We yes, in any case, we use it SOS.
Okay, Dr. Ajit,
We were using electrosurgery.
you are using.
We were using. Yeah.
So, yes, I think there are lots and lots of questions on HCQ. There is one question which has come about 20 times. When will this all end? I don't think we have an answer to that. And Dr. Parikshit, message for IVF specialists and fertility care providers.
Just keep everything on hold. You might get a surprise. Some people might get pregnant at home.
I'm sure.
Resume work. Resume work when. Sorry, sir.
Lockdown effect, and on one side social distancing.
Yeah, so I think the message is that don't initiate fertility treatments at the moment. We'll have to wait until there's more clarity and the curve gets flattened, hopefully in the coming month, maybe. It's just a rough estimate. We don't know exactly when, but most authorities and my personal practice as well as not to initiate any new fertility related work.
Atul, you also please mention the name and place from where the question is.
Okay. Well, that is a little difficult because I've been scrolling the questions, and now it may be a little difficult. I think what we can do is take some of these questions and put them in our FAQs, because there are a lot of repetition of questions. The same question asked by about more than 10 or 20 people. So it's going to be difficult to identify the person now. I've been, for the last 20 minutes, scrolling all the questions. And Parikshit, one more question for you. If a patient wants to come for premarital counseling at this stage, what would your advice be to them?
About getting married in general, or what?
Say they are just married, or they want to plan pregnancy, and
pre-conceptional counseling.
Yeah, sorry.
Yes, pre-conceptional counseling.
Okay, so the first thing is do it on the phone or by video chat. Don't call them to the clinic. Put them onto folic acid as usual. If there are no really, high risk factors, no travel, no contact, etc., life goes on. People are going to become pregnant. We'll take care of them. But obviously, if there is a history of exposure, travel, contact, or if they are healthcare workers themselves, then maybe they should put it off for a month or two.
When there is TOCC, they should be watchful.
Dr. Nozer, are you going to tell your patients not to get pregnant in this pandemic? Are you going to tell them to avoid pregnancy?
No. I am not, like Parikshit said, no fertility treatment at this point in time. I have already had 1 or 2 patients reporting pregnancies. Atul, I don't know. I mean, this is a horrible time for us to be in, but let's not lose our common sense and clinical balance. We cannot stop life. So if someone wants to conceive, I don't see any reason why they should not. We don't know what this disease is doing. My only assurance to our patients is that from whatever, you have to give your patients a silver lining. And I take them back to 2009, when a significant percentage of the mortalities were pregnant women. Now we come forward to the present pandemic, where the total death rate has been many fold greater, but we haven't seen that kind of a disadvantage for a pregnant woman. It's these women and people these days are just grappling at any kind of reassurance. And I think we need to give them reassurance, but to create that kind of a fear psychosis that people should stop having pregnancies and stuff, I think is not sensible, and it's not based in any clinical evidence. Someone spoke about contraception earlier. Yes, we have a concern. And I think that has to be voiced, that there are people who may not want pregnancies, who might be in a situation at this point in time where pregnancies will happen. Yes, we need our ears to the ground because, and this was very interesting for me because organizations working with women's rights and women's issues say that there are going to be situations where when you're closed up in a small space, there's going to be a lot of other problems for women, such as abusive behavior happening. It's not an easy time for people when they are kind of cooped up together. So we are the people who are supposed to look after women overall. So we keep our lines open of communication. Most Foxy members, I mean, I know we've got doctors doing great work in the public sector and private sector, but most of us treating private patients have patients accessing us all the time. And this is the time to give them a patient listening any time of the day or night. My message to them is fluid times. I don't know what will happen next week, but I promise you that you will be looked after one way or the other. And we need to keep brainstorming amongst ourselves. I've spoken to colleagues. I've told them that God forbid one of us is positive. We have colleagues who will step in and look after hospitals. God forbid one hospital has a problem. Others have to be in and looking after. But no, I don't think I'll make such extreme recommendations to my patients.
Dr. Ram, are you there?
Yes, sir, I'm here.
Yeah, Dr. Ram, like Dr. Noza mentioned, there's a question about social abuse of women in these times of unemployment and the husband staying at home. What does the WHO data say about social abuse? Is it only in the West or it's happening here as well?
Sir, I don't have any specific numbers with me, but I totally agree with what Dr. Nozer has said. And we firmly believe that, this is one of the areas that we need to be sensitized about when we are handling the cases, because there is increased chances of violence against women in such circumstances. And also there is an issue where they are not able to air their grievances and they have limited avenues or limited opportunities to communicate outside to seek help. So it becomes very important that violence against women takes, is taken care of as and when we are getting an opportunity of a visit by a woman at our health facility.
Another question, another comment for Dr. Ram, and we'd like you to share the link. I think you shared something with me on email, and I think we'd like to put it on the Foxy website so our members can access it directly. And of course, if you have any suggestions for us members, I think we will take it. It is a difficult time for all of us right now, and a lot of uncertainties. We do not know what's going to happen 1 week from now. So also, what is WHO's recommendation about taking HCQ for prophylaxis?
Pardon, sir? I missed out the last part.
Recommendation for HCQ prophylaxis, hydroxychloroquine prophylaxis.
So we are still awaiting more evidences to come out in HCQ. We currently do not recommend the use of SCQ as per our clinical recommendations. It is one of the drugs which is being tested in the Solidarity trial.
Dr. Ram, it is used by so many countries. Also, Mr. Trump has also asked. Israel people are also asking for the hydroxychloroquine. So everybody, why there is a reason for WHO when everybody is using it, and when it is a non-contraindication, when patient is having no any other contraindication and they are using satisfactorily with no harm. So the molecule is used since so many years. It is not something new molecule. So why there is still waiting for a big trial? See, doctor, all the panelists, Mr. Ajit has also informed that it's a wonderful drug and he has used in all 5 patients. So what is the reason behind this?
I understand, sir, that the use of this drug, especially in the pregnant women, and has not been documented so much till now. And we require a lot of evidences and support of coming out with any particular recommendation, because the recommendations are global recommendations, not specific to any particular country or a continent. So, for us, it takes some time to get all things in place and come out with a recommendation. That is the reason, sir. But simultaneously, sir, as I already also communicated in my communication and comments on the GCPR document, that because this is something which the ICMR has come up and recommended within the country, you know, one observation from my side is that even the ICMR in its recommendations have only recommended it to be used in the healthcare providers as a prophylaxis.
Sure,
So
sir, it is. Yes, yes.
So, sir, I think it is important for us that, you know, as part of the Indian efforts, we need to come up with the documents and publications supporting the observations that we heard today. So I think that will.
Dr. Ram, I am not asking only for the pregnant women. American President Trump might have asked for other patients as well. So I am discussing for overall. Overall, it is useful in, it is believed that it is useful in treating the patient of COVID-19. Pregnant woman is one part of the patients.
Do we have Dr. Chatterjee with us? Maybe we can ask ICMR about it. Dr. Chatterjee, are you there?
Yes, I'm here.
Yeah.
Oh, that's good.
ICMR recommendation.
Thank you for discussing this. There are two clear issues with hydroxychloroquine. One is related to therapeutic use. The other is related to prophylactic use. As far as the prophylactic use is concerned, there have been no trials, and the ICMR recommendation is based on in vitro studies. It is a very narrow recommendation, specifically meant for physicians or healthcare workers who are dealing with COVID-19 cases. And as such, I think it would be it would be ahead of time to expand the recommendation beyond the target group. As far as therapeutics is concerned, that's a different issue altogether. There is some data emerging, but I think the prophylactic use a bit, we need to stick where the evidence is available. And as far as the recommendations go, provide healthcare workers who are in direct management of COVID-19 patients HCQ for prophylaxis.
Dr. Pranab, can ICMR conduct study? Profile of ICMR can conduct study.
He's calling.
Hydroxychloroquine.
Yes, absolutely.
As prophylaxis.
That is something being looked into, but even if the study is ongoing, it would take some time, at least 2 to 3 months, before the data can come through.
Yeah, Dr. Chatterjee, a lot of us are coming across patients who are asymptomatic, I mean, in the low risk category, who have not traveled, elderly people who have been home ridden and with whom I come to contact, no people are coming from. Patients who are at home, not left their house, their contacts have. These are these asymptomatic carriers. So isn't the healthcare worker at risk for that?
So with respect to mild cases or asymptomatic cases, maintaining proper protection using proper PPEs, following hygiene and hand wash guidelines should be enough. As far as exposure to high risk and sustained contact with patients with higher viral loads are concerned, that is something we should be targeting for prophylaxis as the first level of prevention. Right now, we don't recommend beyond that. That is where the recommendations stand at. Definitely, once more evidence becomes available, once more data is generated, that can be revised, and we can always take a relook at this issue.
So
Atul?
Yes, sir.
May I?
Yeah, please. Sir.
Okay, so, it's interesting that, desperate times, desperate measures. I can speak for the practicing average gynecologist. We were told by courts and MCI, no telemedicine. And now, fortunately, we are officially told it's okay, but we got to do it very responsibly. And my request to people is don't just tell people things over phone. Make sure it goes written down in a message, because there can be miscommunication, particularly if you are telling them to take a medication. The second is we are told that off-label use is suddenly okay when we've been told all this time no. Atul, you know how confused I personally was about taking the prophylactic medication HCQ. And everyone who advised me, I've got two equal groups, one strongly telling me take it and another telling me don't take it because it has its risks. Though it's a drug that we've used a lot in pregnancy. I have a large number of SLEs and things I use it for. But I've decided not to. And I've decided not to because we've got two experts here. I am looking after a low-risk population. If that changes what I would do. But you've got two experts here who are telling you based on current evidence that this is something that maybe for that, what you said, 3% of doctors who are actually looking after patients who are at high risk of COVID or who are COVID positive. I'm also told, and particularly by the group of anesthetist friends of mine, that this is not a drug you take lightly. And if you want to take it, you need to have a baseline ECG. And most people aren't doing that. They are just popping the pill at all kinds of ridiculous doses. And that's what I've realized when I've spoken to friends of mine. So let's keep our ears to the ground. Foxy is playing a very important role in communicating evidence from WHO, evidence from ICR to its members, and let's give them responsible information and advice from time to time. But the advice very clearly seems to be, you're looking after these patients? Absolutely. You're looking after a high-risk patient? Absolutely. You've had a possible high-risk contact with someone in your family or surroundings? Absolutely. Otherwise, I don't think it's something that we should. There's nothing. And if you look, I looked at the drug interactions of HCQS. My God, that list of drug interactions is a mile long. And I'm sure most people aren't looking at that before popping the tablet.
I think that broadly covers most of the questions. And I think there are a few more which we have already answered while we were doing the panel. It's been a wonderful panel, evidence-based. I would like to thank Dr. Alpesh Gandhi to allow me to become the co-moderator, and Dr. Chatterjee, Dr. Ram, Dr. Nozal, Parikshit, Ajit, Dr. Neerja, and Dr. Rajesh Matre for sticking to that time and giving wonderful evidence-based messages. I'd hand over the mic to Dr. Alpesh for his concluding remarks.
I think everything very much clear-cut message. So there is no concluding remark from my side, but only thank you very much for all of you for sparing your available time, for your valuable sharing your experiences. All three giant first cesarean section, second cesarean section, and third cesarean section of the country who has performed are in our panel. So they are the best guide to give us guidance for the how we have to manage the patient during labor or when they are admitted in the ward or when cesarean section is going on. We can say persons or the institutes which are very much influencing in policy making. ICMR and WHO are also with us, so we are very much thankful to Mr. Pranab Chatterjee and Dr. Ram Chahar for being with us, and we hope that our liaison, our collaborative work will continue after once the panel is over. Also, we will continue fight against the pandemic, and Mr. Pranab, we are ready. If you wish, we are ready for a study in Indian pregnant woman or any other study. We extend our wish. If ICMR wants anything, we are there. And Mr. Ram, we are also there to work with WHO for the awareness and for many other aspects. So let us continue to fight against pandemic COVID-19. And I wish soon we will win over this pandemic and our country will come out of all these things within next few months, within few weeks or few months without much harm to our pregnant women, our healthcare providers, and our other even non-pregnant patients also. So let us pray to our God for the best come out. And thank you very much once again for being with us.
Also, we are coming out with the FAQ within a week's time.
No, not week time. It is ready. We are coming out within 2 days with the FAQs, and these FAQs are, we come out with the advisory first, then we come out with the GCPR, then we come out with the GCPR with the Pediatric Association also for perinatology. Then we come out with the FAQ is ready, and we also come out with the registry, and we hope the registry will be very much helpful. GCPR, we are also going to come out with the second version of GCPR probably on 15th or 16th April also.
Thank you. Thank you very much.
So any comment from anybody from you, or else we can conclude it here.
Alpesh,
Yes.
I think you couldn't have selected a more appropriate theme for your year.
Thank you.
None of us knew where we would be when we were there at your inauguration. It's like the world has completely turned upside down.
Yes.
But that theme for the year seems almost prophetic. And I think this
That's
is the time to be safe and safe and safe. And thank you for your leadership. I know Foxy presidents have so much planned for their year. I know sometimes it can be disappointing, but you have more than made up for all the plans that you may have had by the amazing leadership you've had at this very critical moment. And trust me, I'm so happy that you're the president of Foxy when women need us the most.
Thanks a lot. Thank you very much for the appreciation, for the support, and for the guidance. All of us being with me. Thank you very much. A very crucial time, very challenging time. Unitedly, as a one unit, we have to fight, and sure we will win against this.
Dr.
Thank you very much.
Say something.
Thank you.
Dr. Chatterjee, are you there?
Sorry, I was muted.
Yeah.
Thank you so much for having us here. The work being done by Foxy to protect the nation's women and the future children of our country deserves the kudos. Indeed, as Dr. Nozer pointed out, that things are really different, but that should not mean that we should move away from scientific integrity and common sense and let not the fear psychosis rule over us. Thank you, Dr. Alpesh. Thank you, Dr. Atul, for conducting this really intense and academic discussion so well. It's been a pleasure and a privilege being on this panel of learned members, and we are eager to take this battle against COVID-19 forward with your help.
Convey our regards to Dr. Raman.
I will do that. Absolutely. Thank you so much.
Dr. Ram.
Thank you so much, sir. Thank you so much for inviting me to be part of this August gathering today. It was a pleasure and privilege, to share some of the insights and the technical knowledge with the audience here. I hope this is going to be very useful for all the healthcare workers within the country. And it was also very interesting and very learning experience for me to understand how the different healthcare providers are managing the COVID positive cases currently, the pregnant women in the country. Sometimes sitting at Delhi, we miss out on hearing about the experiences of the clinicians and obstetricians, which I got to hear today. We'll be very happy to work in the future, to take forward the fight against COVID. I will be very happy to work in any capacity as required in the future with the whole team here. And we look forward to a very fruitful partnership over the year. And let's hope that we are able to return back to normalcy in as quick a moment as possible for us. Thank you so much, sir. Thank you.
Doctor,
Thank you.
do you want to say something? Yeah.
Thank you, Dr. Alpesh and Dr. Atul, for it was a nice experience. Thank you very much.
Thank you. Rajesh, do you want to say something?
A very nice experience.
Yes.
Excellent session. Thank you, Foxy, Dr. Atul, Dr. Alpesh. Thank you very much.
I'm on webinar. Can we talk about 15 minutes?
Dr. Nirja, would you want to say something?
So just one point that, one hopes the lockdown will not last and we hope we get back very soon, but we don't know how things will be. So we have been encouraging more and more of PPIUCD so that 6 weeks down the line, in case we are still not encouraging women to come forward very quickly for their PNC check, we at least have the comfort that we got the PPIUCD there.
Thank you. That's a wonderful concluding remark. And Dr. Alpesh, and on behalf of Parikshit and myself, thank you for making us a part of the first version of the GCPR. Parikshit, are you there? Parikshit?
Yes.
Yeah. So I think just one concluding remark from you and we'll close the session.
What can I say? Of course, thanks. And I suppose life goes on and we have to wade through it as it comes. And I wish everyone all the very best in these really difficult times.
Yeah. I think
Stay safe, stay healthy, stay home, stay connected on social media.
Yes.
Thank you. Thank you very much.
Thank you. Thank you.
And stay safe, sir.
Yeah, thank you.
Yeah.